Hello, and welcome to the Cardiology Podcast, Why We Do What We Do in Cardiology. In this audio series, we will discuss the practice-changing articles in cardiology from the past to the present. This is your episode for today.
In this episode, I will discuss about the title Optimization of Evidence-Based Heart Failure Medications After an Acute Heart Failure Admission, a secondary analysis of the STRONG-HF randomized clinical trial. This was published in the journal JAMA Cardiology on December 27, 2023. First author is Gad Cotter from France. The study was stopped early per Data and Safety Monitoring Board recommendation because of greater than expected between-group differences. Total patients screened were 1,641. Total randomized participants were 1,078. Study terminated on September 23, 2022. Mean patient age was 63 years. Percentage female was 39%. Percentage of blacks was 21%. Inclusion criteria: age 18 to 85 years. Admission within 72 hours before screening for acute HF. Hemodynamically stable. NT-proBNP more than 2,500 picogram per ml and more than 10% decrease between screening and before randomization, but still more than 1,500 picogram per ml. Without treatment of optimal doses of oral HF therapies within 2 days before hospital discharge. Exclusion criteria: intolerance to beta blockers, ACE inhibitors, or ARBs. Other salient features: characteristics: 29% with acute coronary syndrome, 29% with diabetes, 22% with New York Heart Association Class 4 HF 1 month before hospital admission, 15% with left ventricular ejection fraction more than 50%. Baseline left ventricular ejection fraction was 36%. Cardiac resynchronization therapy at baseline was 1%. Patients with acute heart failure who receive closer to optimal doses of guideline-directed medical therapies, GDMT, within weeks of hospitalization experienced significantly better outcomes compared to those receiving lower doses. This key finding comes from a post-hoc analysis of the STRONG-HF trial, highlighting the importance of aggressive optimization of GDMT treatment for improved patient outcomes. The analysis focused on patients in the high-intensity care arm of the STRONG-HF trial, which compared a rapid up-titration and close follow-up approach to usual care for acute heart failure management. Notably, over 90% of patients in this arm reached at least 50% of the optimal doses of GDMT on average at 2 weeks. However, some patients didn't reach full optimal doses, prompting researchers to investigate the impact of varying GDMT levels on clinical outcomes. The analysis divided patients into 3 groups based on the average percentage of optimal doses achieved for the 3 main GDMT classes at 2 weeks: low dose, less than 50%, medium dose, 50% to less than 90%, and high dose, more than 90%. While clinical outcomes at 6 months didn't significantly differ between these groups, each 10% increase in the average percentage of optimal dose achieved was associated with lower risks of heart failure readmission or death, adjusted hazard ratio, HR, 0.89, indicating an 11% reduction in risk for every 10% increase in GDMT dose. Lower risks of death alone, adjusted HR 0.84, implying a 16% reduction in mortality risk for each 10% increase in GDMT dose. Greater improvements in quality of life: patients achieving higher GDMT doses showed better scores on a quality of life scale at 90 days. However, achieving higher doses wasn't without its challenges. Patients with less stable clinical conditions, such as lower blood pressure, more congestion, and lower kidney function, were less likely to reach full optimal medication levels at 2 weeks. This suggests that while many patients can tolerate and benefit from aggressive GDMT optimization, individual considerations and tailoring of treatment based on patient characteristics are crucial. The findings emphasized the importance of the study in clarifying the ongoing debate about GDMT underuse in heart failure. The analysis reveals a large proportion of patients can achieve significant levels of GDMT, suggesting therapeutic inertia plays a major role. However, the presence of genuine intolerances in some patients, highlighting the need for individualized assessments and treatment approaches. Overall, the STRONG-HF analysis provides valuable insights into the benefits of optimizing GDMT in acute heart failure patients. By demonstrating the improved outcomes associated with higher doses and the safety of a rapid up-titration strategy, the study offers clear clinical implications for aggressive GDMT optimization while emphasizing the importance of patient-centered adjustments to ensure tolerability and maximize benefits. This research presents a significant step forward in improving heart failure management, offering a solid framework for implementation of effective treatment strategies and ultimately bettering patient outcomes.
Thank you for listening to this podcast, Why We Do What We Do in Cardiology. The information in this podcast is for general information only for medical professionals and is not intended to be a substitute for medical advice from a qualified healthcare professional. We hope you found this information helpful, and we look forward to seeing you on the next episode.